reduce. Yeah, I think we are live.
We are live. Yes.
Good evening, everyone. So I welcome all of you to this 81st masterclass and the series on adenomyosis. So this will be the third session this week on adenomyosis. So we finished stimulation protocols for IVF and non-IVF cycles, and today we will be discussing about embryo transfer techniques and practical aspects in adenomyosis. Yeah, over to you. You can start.
Yes. Just see if you can see my screen.
Yeah, can see.
Can see, no? Okay. Okay. So here we go. This is a very simple flowchart. Okay. On how to do endometrial prep for embryo transfer. This is specifically for adenomyosis. Okay. Just remember the golden rules, which I am going to state. Again, as we know, we have divided endometriosis into three categories. One is focal, second is diffuse, third is focal adenomyosis of outer band. So we know the criteria, right? Basically, focal less than 3 centimeter, more than 3 centimeter, diffuse where uterine size is less than 10 centimeter, more than 10 centimeter. Focal adenomyosis, nobody cares. Answer is only laparoscopic surgery. Okay, so now after laparoscopic surgery, you have finished the egg pickup. So you have finished the OPU, and now is the time for embryo transfer. So in embryo transfer, there is standard HRT protocol in this case. No changes. No changes at all. This is one case where you don't worry about endometrial myometrial junction, as it will be normal in 90% of FAOM. Okay, so FAOM is finished. No controversy, no applying your head. Okay. Now, when you have focal adenomyosis more than 3 centimeters or diffuse more than 10 centimeters, in these two cases, the answer is you are supposed to start with laparoscopic surgery. Laparoscopic surgery. Okay. And of course, in the laparoscopic surgery, while doing the laparoscopic surgery, you have again two criteria prior to doing this. Okay. I will just label them in black color. Endometrial myometrial junction was normal, and I will label it in red color. Endometrium myometrial junction abnormal. Okay. Abnormal means it is skewed, it is hazy, punctured, unable to see it correctly, and all these types of things. Okay. So if the endometrial myometrial junction is normal prior to surgery, the rule is simple. HRT protocol. Standard. Huh? No changes. Whatever you are following, so we have discussed that many times, just standard. Nothing to be done. If the endometrial myometrial junction is abnormal, okay, now this is interesting. In both these situations, can try letrozole plus registrone for 100 days. Again here, can try letrozole plus registrone for 100 days. Okay, this is after OPU. Okay, and then take for standard HRT protocol. But remember, when the endometrial myometrial junction is abnormal, the success rates are going to be less than 20%. I will also come to the point which everybody loves. Array, why we are not using Lupride Depot? I have used Lupride Depot and I have given 450 shots of Lupride Depot, and I'm extremely happy with the outcomes. Remember the leupride depot one, it has got no effect on endometrial myometrial junction. It doesn't reduce the volume very effectively. Yes, I know 99.9% will be doing only this because what will happen is that is the easiest way out. Nobody wants to give this patient to an endometriosis or a adenomyosis surgeon because very few people are actually operating. So I can understand the fear in the mind of people for doing this. All right. And now we finally come to what we do in focal adenomyosis less than 3 centimeters, diffuse adenomyosis less than 10 centimeters. How do we go about these two people? So let me just club both of them together. Again, in this situation, your breakups are going to be very, very simple. Is the endometrial myometrial junction, sorry, I was supposed to put it in red color. Is the endometrial myometrial junction abnormal or is the endometrial myometrial junction normal? If it is normal, we already know standard HRT protocol. If it is abnormal, we already know can try letrozole plus regestrone for 100 days and then switch to HRT protocol. Correct? Very simple. Now comes the question. Why are you not trying modified natural cycle in adenomyosis? The reason is many a times adenomyosis is associated with endometriosis, and in that cases it can also have low AMH and it can also have peritoneal endometriosis. As a result of which, when I try modified natural cycle, it can end up in luteinized unruptured follicle syndrome, which can grossly affect the endometrial synchrony, and as a result of which, I don't give so much preference to that. Comes the question, why not loop right depot in all cases? So I have already given the answer to that. Okay. I have already described what is the type of embryo which you need to give, which is a day 5 embryo in all these cases. I have already described the rest of the things. Do we need to add? I'll quickly give you the role of the other time pass adjuvants also. Role of everything which has no role, I will write down in, let's say, pink color. Okay. Low molecular weight heparin, arginitric, sildenafil. What else people give? Deepa madam, what else people give?
Prothon,
CoQ10. Huh? What?
GCSF, PRP.
GCF. Yes, yes. GCSF, PRP. All these boys and girls have no role. The only guy who has a role is endometrial myometrial junction. So then another question will come. Arey Jai, you are a big proponent of stem cell therapy. But remember one thing, you will almost never see me propagating stem cell therapy as far as the adenomyotic uterus is concerned. Okay. The reason why we never propagate stem cell therapy in an adenomyotic uterus is you have to understand what is adenomyosis. Adenomyosis is basically altered myometrium. Why is the myometrium altered? Myometrium is altered because the myometrial fibers become thicker with the same amount of blood supply. So what does it do? It causes the arborization pattern of the blood vessels coming inside the uterus to be altered. Because the arborization pattern is altered, there is a problem at the endometrial myometrial junction. Because of that, there is some amount of hypoxia at the endomyometrial junction. Because of which, there is some fibrosis at the endometrial myometrial junction. And because there is this fibrosis, endometrial myometrial junction is bloody important as far as adenomyosis is concerned, and nobody can change it. Okay, which is why in so many cases we were discussing of bad diffuse adenomyosis, where we say, oh, it is a bad diffuse adenomyosis, but the patient became pregnant. She became pregnant because her EMJ was good. Okay, the reason why in some people EMJ is good and some people EMJ is not good is yet to be researched. Okay, even I don't know. But I can tell you one thing. There are some women in whom, instead of the natural arborization pattern, you know how the arborization pattern is. Uterine artery curves along the lateral pelvic wall, lateral wall of the uterus. It branches perpendicular. After it branches perpendicular, it again gives perpendicular branches close to the endometrium. And those guys will penetrate the endometrium perpendicularly. Correct? That is how the system is. We have all by hearted this and forgotten also. Okay, as a part of post graduation. But in adenomyosis, this changes because in adenomyosis, especially in diffuse adenomyosis, this crisscross pattern in which the vessels are going in, these vessels would suffer hypoxia. They would suffer hypoxia because a lot of their energy goes in giving vascularity to the endometrium, which is now present inside the myometrium. Understanding? That is the problem, which is why there is EMJ distortion. So whenever there is EMJ distortion, no, you should be mentally ready to accept that it is going to be a bad adenomyosis. It is going to be a hard adenomyosis. Understanding? And you will see this very, very commonly. If you are operating adenomyosis, this is something which will be like on the tip of your fingertips when you operate. Trust my word on this. I am the most unsuccessful IVF specialist practicing in the country. Okay, with the least amount of success rate as far as this particular disease is concerned. But I can tell you one thing for sure. Okay, one thing for sure, that if the endometrial myometrial junction is abnormal, and even if there is a pregnancy on it, chances of abortion are very high. Chances of placenta getting adherent is very high. Chances of having retained placenta is very high. Okay, in all these three situations, despite giving everything. And finally, let me conclude. There is no role of LIT in adenomyosis. There is no role of stem cell therapy in adenomyosis. There is no role of any of these immunological aspects as far as adenomyosis is concerned, because adenomyosis is basically an altered uterus. Okay, and this altered uterus is not going to respond to microscopic factors unless you go and correct the macroscopic factors, which is why the role of laparoscopic surgery is superbly important as far as adenomyosis is concerned. Okay, so I know that throughout this lecture for the last 15 minutes, I have challenged a lot of concepts which people have ingrained in your heads. Okay, but if you listen to this lecture and if you go and follow one patient of adenomyosis, you will be able to correlate that 80% of the things which I am stating are absolutely picture perfect. Okay, so now we'll answer questions from Shilpa madam.
Do you do surgery for all patients about 10 centimeters and focal adenomyoma of more than 3 centimeters?
Yeah,
And these cases, like, say, if it is borderline, say 11 centimeters, and the patient doesn't want surgery, and you have said, okay, I will do volume reduction with letrozole, registron, and then do the transfer. So in such cases, do you think the technique of embryo transfer is easier in cases where you have done a surgery or where you have not done a surgery? I mean, is there any difference at all?
it depends. Okay, on how the surgery has happened. Usually, what will happen is once there is volume reduction, okay, the posterior myometrium will undergo fibrosis. Okay, along with that, it will ensure that a part of the endometrial cavity, see, endometrial cavity is like a concave shape in adenomyosis. It will not make it concave, it will make it straight, but it will also make it tubular. Okay. So what will happen is many times you will have some blood spot on the outer catheter in patients with adenomyosis. Inner catheter will be clean, but having a little blood spot on the outer catheter is normal because the outer catheter is hooked. Okay, it is not a straight catheter, it is hooked, so it goes and impinges on one part of the endometrium. But apart from that, nothing special.
So in these cases, I know you don't do the embryo transfers under ultrasound guidance. So do you do them
I
under?
do, I do, I do 50% embryo transfers in ultrasound guidance. Bapre.
Exactly. I mean, not all, like we do 100% under ultrasound guidance. So, in adenomyosis, I mean, do you make sure that you do all the cases of adenomyosis embryo transfers under ultrasound guidance?
Yeah,
Because
yeah,
it is skewed endometrium
yeah, yeah, 100%.
and do you do it with partially full bladder, or the uterus is so globular and it is so big that you
No,
don't have?
it is not so globular, no, because the size would have gone down to less than 9 centimeters.
Mm, mm, mm. So you will still do it with partially filled bladder or full bladder.
Yeah,
And
yeah.
okay, stop yawning. I mean, these are interesting questions. So do you use uterine relaxants like atosiban for
No,
adenomyosis, where you think that the
nahi, nahi.
no? Okay. And endometrial scratch, do you think it has
Don't
any?
do. No.
What do you think is the risk of ectopic pregnancies? Because especially post-surgery, when the
And the
tube,
tube will be cut in so many surgeries. So no risk.
no, if it is not cut, if you are not doing it, if we are salvaging the all the organs as they are.
No, no, your sutures will only go through the tube sometimes. So don't worry.
Okay. And the embryo transfer catheter. So if there is a large uterus, if the volume of the uterus is more, I know you don't transfer, you do the surgery and then transfer. So people who don't do surgery, okay, so where the uterus is about say 12 centimeters and they are doing an embryo transfer. So do you think they should use a different embryo transfer catheter, which is a longer one?
No,
So the Cook's, like the knob which comes, you just pull it out and then you insert it.
just make it 5 centimeters and put it.
Yeah, yeah. And what is the role of steroids and thymosin?
No role of both.
Even thymosin?
No role.
So, talking about the factors which contribute for success, you spoke only about the endometrial junction. Uh,
Yeah.
uh, you think because you
No,
are
I'm talking of endometrial myometrial junction after assuming that the embryo quality is good.
yeah, yeah, yeah. That is for given. I'm talking only about adenomyosis as a disease. So you think more than the volume. So if a patient of adenomyosis with a 8.5 centimeter length compared to like 9.5 centimeters, you think the lesser the volume, is it better, or it is mainly about the endometrial?
Junction.
Do you think tamoxifen can be an advantageous thing if the lining is thin? Because in adenomyosis, we see many a times that the endometrial thickness is quite like, I mean, quite thin, and we
I
find
am
it.
not a fan of tamoxifen in adenomyosis because tamoxifen causes that little bit of subendometrial edema. Okay. It can give you a false sense of gratification that, oh, endometrium is good. But actually, that endometrium is not very good.
Uh, so what do you think about ecosprin?
Good,
Because
good. Give.
and probiotics,
I don't give.
you don't use it in adenomyosis. And have you seen coexisting focal adenomyoma and a form, or a diffuse adenomyosis with a
Yeah, yeah.
form?
Common. Common, common.
It's quite common.
If
And
if anything is present, let's say you have diffuse adenomyosis with foam, then the diagnosis becomes foam.
why?
That is because the focal adenomyotic of outer myometrium is a much more important thing to be solved because it is also going to have deep endometriosis. 95 to 98% of the times it will have a nodule. So it's basically 100% of the time.
Mhm.
Okay. And these women will be in pain. Don't worry. They will be in pain. Okay. See, this concept of not operating is usually for women who want fertility and don't have pain. Okay. There is no concept of ignoring the pain and giving fertility. That is only an Indian concept. Okay. That is not even published in any papers anywhere on earth. Okay. So if you have pain, pain is to be addressed. What we do is we address fertility. we don't address pain, which has to change.
Mhm. So what is your take on like choice between single embryo transfer and double embryo transfer in adenomyosis cases? Is it
So
like,
up to people. Yeah, whatever
okay,
you want to do, it's okay.
okay. Uh, so have you seen that there is difficulty in negotiating the internal loss in cases of these adenomyosis?
No,
Not really. And what about these cystic adenomyosis in the subendometrium? Do you do hysteroscopy for all cases of adenomyosis? First, you tell that, and then we'll talk about this.
better to do.
So I think that should be a point, right? I think
Yeah,
we
it
should.
is better to do.
Okay. And the cystic adenomyosis, do you see that often? How many percentage of adenomyosis cases do you see that?
5 to 7.
So have you found it difficult to visualize the endometrium in cases of adenomyosis, especially if it is anterior adenomyosis, and have you found it difficult to do the embryo transfer, as in like the technicality?
No,
Not really. Mm. Yeah. What about embryo glue? Do you think it adds value in cases of these adenomyosis cases?
you want a
Okay.
scientific answer?
No, no, it's fine. Thank you. You asked.
Yeah,
Okay, so you give letrozole and registron, and do you document the volume reduction all the time, or you just
yeah.
blindly see
No, it's documented.
it's documented, and the very
Yeah,
next time you go ahead with the embryo transfer, right?
correct. Yes, next cycle.
Okay, and is there any change in the post embryo transfer protocol? Like, do you
Nothing.
supplement of
No,
progesterone more?
no,
Uh,
nothing.
Nothing at all.
No,
Have you offered ERA for these cases? Do you think there is asynchrony between the
no role.
endometrial? You don't think so?
No, there
The
is no role.
Okay. And do you think sequential transfers in these cases might help?
It's abandoned, outdated.
Hmm. Okay, I think that's about it. Yeah, but it was wonderful. Huh? I mean, the 3 sessions on adenomyosis was very, very good. Very focused sessions on adenomyosis when there is hardly any literature where they have spoken about the practical difficulties that we find as clinicians. I think these 3 classes were really, I think, one of very good sessions of yours. So thank you very much for sparing your time and doing this for everyone. Thanks everybody for joining us.